asked him to compress 30 years of ophthalmology into 7 minutes. So, optical PK, well, we'll start with this. I thought we'd do case examples. So this is a case of an elderly lady. She's got an obese thick neck, so the anesthetist is already screaming. And she's single-eyed. She's got a very small eye, an axial length of 19 millimeters, and this color of cornea. Obviously, she also has lag of thalamus. There may be a possibility of HSV. There is also a limbal stem cell deficiency, and as mentioned earlier, this is a high-risk graft. And also there is a coexisting cataract. So how do you go about this case? So you start off as per normal. You mark the center. You make sure it's equidistant from all 4 parts of the limbus. This is quite important when it comes to centering your graft. And then after this, you make a peritomy so that your sutures don't intersect the vascularized area. Also, you have to address the limbal stem cell deficiency as well. So that helps post-op. Now you start off first by marking the post. You don't actually you don't refine through. You just make a 60% depth trephination so that you cut all the stromal vessels and the bleeding stops by the time you come back to do your final trephination. Once you've done this, once you're sure that you've gone to an adequate depth, you can then leave the trefine there and then you can move on to your donor. Now the donor, you please check the other side to make sure you're not including the arcus in your dissection. Once that's okay, you then punch through. Also check the trefines because they sometimes can be blunt and you will have an irregular edge. Once this is done, you make a final cut through. As you're cutting the cornea, you have to be sure that you're making vertical cuts on the side wall, otherwise your graft host will not oppose and it can lead to horrendous astigmatism and can also cause late onset graft ectasia. Once this is done, you now go on to tackling the cataract. Now we use trypan blue in all our cases to stain the capsule, and then this is the next step. This is the capsular rhexis. Now you can do a can opener as well, but a capsular rhexis offers you 2 distinct advantages. One being that it allows you easy cortical cleanup, and the second thing is it also allows you to slip in the IOL a lot better and into the bag. So that allows for better outcomes, especially when you want to plan a regraft in the future. Now, the capsular rhexis is done blind. It is pulled under the rhexis margin, so it's more about tactile sensation. So you make sure it's, as long as you can see the intersection of the 2 flaps, you know where the rhexis margin edge is, and therefore you just continue to pull until you form a complete rhexis. After this, you then move on to the hydro. Now the hydro again is very, very crucial in this case because you have to make sure that you do not include the epinuclear sheet. You have to dissect the entire nucleus out of the bag in one go. If you leave cortical sheets inside, it's very difficult to clean up in open sky. So once you have the nucleus out of the bag, you can then go in. Simple Simcoe cannula will suffice, although you can use my manual as well. So you go in gently. Your rhexis allows you the safety of doing the IA quite easily. This is then you check the bag whether everything is clear, and once that's done, you just inflate the bag a little with a little bit of visco, and then you slip the IOL in. Now the IOL goes in with the leading haptic into the bag. You catch hold of the trailing haptic, don't let go. Then you use your second instrument to then push it into place. Now how do you know when the IOL has gone entirely into the bag is, as you keep pushing, you will realize that there will be a bit of a resistance. That's when the haptic is hitting the edge of the bag. And when you see this sort of satisfactory snap of the pupil, and when it becomes wrong, that's when you know it has gone in completely. A PI is mandatory. You can choose to do it either superiorly or inferiorly, depending upon your indication. Then you put in a little bit of visco to form the ankles, and then it's now on to suturing. So how we put continuous sutures. So you start off with 4 cardinals. You do lock all the first 4 cardinal sutures. They're taken at 90% depth, so in both the graft and the host. And once you've done that, you then put in the next 4, but don't suture them, don't lock them. You then fill the chamber with air to a physiological sort of anterior chamber depth. And once this is done, you can go ahead and complete the continuous suturing, and then after that, remove the cardinals. Now we still have to address the limbal stem cell deficiency part. So this is the same donor. So you're harvesting the limbal tissue from there. Now because it's a one-eyed lady, you don't want to do a slet because that delays visual recovery. So this is more of a limbal stem cell allograft. So you use fibrin glue to sort of stick the allograft in place. And once that is done, you then move on to closing the conjunctival peritomy. Now you can do this with glue as well, but if you like, you can use sutures also, because you want to have good airtight closure over the limbal stem cell allograft. And finally, to address the lag of thalamus, this is a permanent lateral tarsography. Now, PK can be glamorous as well. So this is a child who basically had an IOL that had popped out of the back due to the superior iris defect. So this is pupiloplasty. But the only thing you have to remember is two things. Number one, take your bites in the good part of the iris. Do not use the shaved part, because that will make sure the suture will cheese wire post-operatively. The other thing is, always use Prolene. Do not use nylon, because nylon in the AC will tend to degrade over time. First, you will see that you automatically have a PI superiorly, and then you can stop. Yes, the child did move during anesthesia, so it's going to come out during the same time. So if you have a superior defect large enough, you can leave it alone. And lastly, if you have a case like this, where you want to go in and exchange the IOL, so we're just basically not exchanging it, we're repositioning it. It is a foldable IOL. So this is, we're just basically repositioning the IOL by doing suture fixation. And what you can do is, before you open up the graph, I'll be happy to take any questions after this. Wonderful. So this one's mine. So today I'll be discussing about DALC as well. So like the earlier speaker was mentioning before, you have anterior lamellar keratoplasty and then you have deep lamellar. When you have deep lamellar, you basically have two types. You have the descemetic DALC and you have the pre-descemetic DALC. Now, coming to the pre-descemetic DALC, we have only one person to thank. That's Dr. Mohammed Anwar, who gave us the big bubble technique. So basically, you use the force of air in order to separate the pre-descemates from the stroma. Now coming to instrumentation, you have multiple options. You can either choose to use a 30 gauge needle or something like this, which is the Fogler air injection cannula that has the port facing downwards. It allows you to inject the air down onto the pre-descemate and not into the stroma. Now, so this is a type 1 bubble. You can see it formed now. So how do you know that it's a type 1 bubble? It's very simple. It's basically, it starts from the center and moves peripherally. It's well circumscribed, it's got a dome shape. It only will extend to 8 to 8.5 millimeters, because that is the anatomical limit of the pre-descematous layer. And then it also has a white sort of emphysematous border at the edge. This, on the other hand, is a type 2 bubble. So when you see the bubble starting, you will realize that it's a little different from the type 1. The reason being, it starts from the periphery. You can have multiple type 2s which can coalesce as you keep filling the chamber, and this can extend all the way up to the limbus as well. And if you notice, it's got sort of a glassy appearance. That's because it's the stretched pre-descemates on top and the stretched descemates membrane below. Now, this man was, obviously we all know, is the person who gave us the concept of the pre-descemate. So basically a layer that's just above the endothelium that's so resilient that it can take the force of an air bubble even when the chamber is inflated to an artificially high IOP of say 60 to 70 millimeters of mercury. Now, what is a type 1 bubble? It's basically a bubble that just splits the pre-descemates membrane away from the stroma. So below the bubble you have both the pre-descemates as well as the descemates layer. Whereas a type 2 on the other hand is when you have the bubble formed between the pre-descemates layer and the descemates. So this is not but what we want, at least intraoperatively. Then you can have a type 3 as well, which is a mixed bubble. So this is from the archives basically. So this is when the understanding was a lot poorer, as you can see the videos from 2007. So intraoperatively it's actually a type 2 bubble which they're now injecting visco into. So the surgeon still doesn't know, and they've actually managed to cut through the pre-descemates as well. And when they go close enough, the descemate is not as resilient and you have this. You basically have a perforation. You see once more, just the touch of the scissor is enough to perforate. So in this case, at that time the concepts of saving a DALC were not there, so at that point you just had to convert. And thankfully the patient also had a cataract, so you end up doing a PKACC IOL. Nowadays, it's quite different. So this is my case from recent. So as you can see again, there's a mixed bubble. You can see around it's mostly pre-descemate, but superiorly alone you can see the type 2 bubble. So you leave that place last, you make sure you dissect all around, and when you go to that part, just be as careful as you can, stay far away. It doesn't matter even if you don't get the perfect ledge there, you can always trim it later, but don't try to force your scissor in there because it can perforate at any given point in time. So once you slowly manage to tear away the rest of the stromal ledge, you can then now move on to tackling the bubble. And the way you have to remember, this is nothing more than a separation between the predesmates and desmates. So, yeah, so that's just removing the stroma. Now, you just want to tack, you just take a sharp instrument, can be a needle, can be a side port as well. You just give a small nick at that area, and then you'll instantly see that the desmate just opposes. Now, in some cases, no matter how hard you try, you may not get a bubble. This is one of those cases. So, multiple air injections, you're just getting stromal emphysema. So, in this case, once you've tried maybe 3-4 times and you don't have any more places to inject, you can then move on to doing what's called a manual layer by layer talc. Now, it's not, you will still leave behind a bit of tissue at the end, but even these cases can have great outcomes.